Mark?
I can.
Yeah, I'm switching on the live stream now. We have got another 2 minutes to go.
Okay.
Almost 50 people, and people are getting added every minute as we talk. So once you start your talk, you can just go at one stretch and finish it from start to finish.
Okay.
And then we'll ask all the questions posted by the viewers on YouTube channel, and you can answer them. And at the end of the presentation, you just exit your screen share so that we can see your full screen. So Mark, it's 7 o'clock.
Okay.
We'll start now. Allow me to say a few words about this event and about you. So hello everyone. Hello everyone to all the IAPS members and viewers who are watching this webcast all across the world. We welcome you once again to yet another episode of IAPS webinar. Today we have Dr. Mark Davenport with us, who will be presenting on choledochal malformation from Waiter to Vietnam. Dr. Davenport needs no introduction. He is an accomplished surgeon and past president of BAPS and professor of pediatric surgery. He has very well published in the field of hepatobiliary surgery, most prominently biliary atresias and choledochal malformations. And today, thank you, Mark. Thank you for accepting this, doing this presentation on the platform of IAPS. And we welcome you on behalf of the IAPS president and the entire community of IAPS. Last year, we saw Mark presenting about biliary atresia in the Indian Association of Pediatric Surgeons annual meet at Chandigarh. That was really a good talk. And today here we have him again for the choledochal talk. So without any further delay, Mark, I'll hand over the stage to you and you can go ahead with your talk. Thank you once again.
Thank you very much for that kind introduction, Ravi. And again, my thanks go out to the organising committee, really, the Indian Association of Pediatric Surgery. It is true that I presented on biliary atresia last time, and I thought actually I would try and widen people's experience of choledochal malformation. It's more likely, I think, that your audience has come into contact with choledochal malformations more than biliary atresia. I've subtitled it From Vata to Vietnam. So when we get into the suburbs of Hanoi, you'll know we're on the home stretch. Okay, so what are we going to talk about? I'm going to offer you a classification. Now, I know most of you perhaps will be familiar with the Tadhana classification. This is a modification of his classification, but it's based a little bit more on the pathophysiology rather than stamp collecting. We call it the King's College Hospital classification. And as I say, it's based on actual evidence, observational evidence, and from 4 studies which we published on our clinical series. Of course, you're all surgeons, so you know about surgery and you'd like to debate the merits of how to do this operation. I'm going to present to you some details of my series, my experience, which is an open experience, but we will discuss the merits of laparoscopic choledochal malformations as well, and also come to this really knotty conundrum of which kind of reconstruction to use, hepatocogeginostomy, the root loop, or hepaticoduodenostomy. But I promised I would start with Vata. Here's Vata. This is a man with a wig. And that wig simply presents him in the 18th century. He was a German anatomist working in Wittenberg. And in 1720, he produced his master work, his magnum opus. And as you can see, it was written completely in Latin, as they were at the time. But even those who have no real knowledge of Latin can probably work out what it's going on about. It's going on about the ampulla of Vata. And what he described was this really unusual anatomical arrangement where the distal common bile duct and the distal pancreatic duct join within an ampulla, but have two separate sphincter mechanisms to ensure that their contents do not mix unless they're inside of the duodenum itself. But for the purposes of this particular presentation, the reason I'm talking about him is because he was the first person to describe a choledochal cyst in 1723. You perhaps didn't know colour photography had been invented by then. This is a choledochal cyst, a classical choledochal cyst. You can see where it starts. You can see precisely where it ends. That looks a very normal common bile duct beyond it. And there's the pancreatic duct as well. That's a choledochal cyst. Cyst is actually a word, English word, derived from the Greek word, which means bladder. And knowing that, you know exactly what the operation of cystectomy now is. It's called a cyst because it's round, it's globular, it's spherical. All the characteristics that we've just been talking about for choledochal cysts. This is not a choledochal cyst. Both of them are choledochal malformations. Indeed, if this one on the right-hand side was your bladder, you really need to see a urologist. So we call this now a cystic choledochal malformation, and this one a fusiform choledochal malformation. So I'm going to stick to those terms throughout this particular presentation. And that is a fundamental divide that we have in what's called the type 1 choledochal malformations. Now, you'll also notice that they both have this in common, every pun intended, and that's the common channel. So here on the left-hand side, you can see that's the common channel there. Over here, it's a bit more difficult to see where the common channel is. That's because it's distended and it's stuffed with debris and stones, so much so that the contrast is not really going through it. It's going back into the dilated pancreatic duct. There's a stone there. It's also trying to circumvent the obstruction by going this circuitous route via the accessory duct. But there is the common channel in this particular case. It won't surprise you to know that this particular child was a 9-year-old girl who presented with pancreatitis, a common kind of presentation for these types of choledochal malformation. Now, we've tried to define what choledochal malformation means to us, and we've used this definition. It's a morphological abnormality. It's an abnormality of shape and characterized by dilatation. The fifth part, in the absence of functional obstruction, well, that's a kind of strange thing, really, because we know some of them will present with jaundice, but for most of their natural history, they're actually able to transmit bile from the liver into the intestine and not functionally obstructed. The idea of the addition of this particular clause is simply to exclude the scenarios where you've got a normal common bile duct and someone ties it off, or a gallstone impacts into the distal end of the common bile duct and that causes dilatation. That wouldn't be a choledochal malformation, though. Okay, so let me give you the King's classification. So we have two types, cystic and fusiform in ours. Tadhana, by the way, has 3, but I dare you to actually try and define them. So we then followed on with type 2, which is an uncommon thing, a diverticulum. Type 3, again, very uncommon, and I hadn't seen one until a couple of years ago when a 14-year-old boy was referred into King's, and he had a 3-year history of undiagnosed abdominal pain, and that was despite 2 ERCPs by admittedly adult endoscopists. And we brought him across to King's to repeat the ERCP, and here it is on the left-hand side. What you can clearly see is a localized dilatation of the distal common bile duct in the wall of the duodenum. That's a choledococele. It's obviously analogous to a ureterocele. And this was unroofed endoscopically by our endoscopist, and he never has had any abdominal pain since. Choledococele. We've got a type 4, different from the Tadhana. He describes type 4A and B. Again, I'll dare you to actually define that. We use a more functional division. And again, I'm going to try and show you some justification later on. Type 5, it's worth spending a moment on type 5. Most of them seem to have corollary features. That is, they are like this. This is an ERCP of a typical corolles. You can see a very normal common bile duct, no common channel, normal cystic duct. But what you can see is these multiple discrete saccular dilatations scattered throughout the liver. Now, corolles itself is completely different from all the other types of choledochal malformation. We know, for instance, it's genetic. We know the gene for it. We also know that it shares pathology with the kidney particularly. So these children have often got renal fibrosis, even chronic renal failure, renal cysts, and they have an early tendency to liver fibrosis as well, completely different disease. So we thought we'd try and look at the etiology of what's behind the choledochal malformation. And indeed, there are two competing hypotheses. One is a very familiar hypothesis to most pediatric surgeons because we've seen it. We've seen it in jejunal atresia. We've seen it in esophageal atresia, when in both circumstances, there's proximal dilatation. And in this particular instance, the idea is that there is a distal common bile duct stenosis, a proximal rise in pressure, which causes the dilatation. But there is an alternative to hypothesis in the choledochus, and that is this so-called Babbitt hypothesis. And the Babbitt hypothesis is where there is reflux of activated pancreatic enzymes getting back into the bile duct via the common channel. And when they're in the bile duct, they cause destruction of the mucosa, weakening of the muscular wall, and dilatation. That's the Babbitt hypothesis. There's Donald Babbitt. He was an American radiologist working in the Midwest, and he wrote 2 papers describing 7 patients. Never went near an operating theatre. And this is entirely what we would call a thought experiment. So we had no actual evidence for the hypothesis. And I've just reproduced this picture from one of his presentations. And you can, there's a beautiful choledochal cyst, cystic choledochal malformation. There's a beautiful common channel there. And what he observed was simply the reflux. And he reasoned that if the contrast could come out and go back into the pancreatic duct, then perhaps the opposite could also be true. So that's his hypothesis. Schematically, it's where pancreatic juice gets into the bile duct. Now, amylase, I'm going to mention amylase a lot over the next few slides. I'm not suggesting that amylase itself is the enzyme that does the damage, but we can easily measure it. And therefore, it's a surrogate of the amount of pancreatic reflux that you get into a bile duct, biliary amylase. Okay, the idea is that Babbitt's hypothesis, this all occurs at normal pressures. The obstructing segment hypothesis suggests there's a narrowing down here, higher pressure, and that causes dilatation. So we've written 4 papers on this. The first was published in 1995, a long time ago, based on a clinical series of 55 children, and we were measuring the level of amylase in bile. Now, you shouldn't have any amylase in your bile. And what we first noticed was that there was a marked association with increasing age. So the older you were, the higher your bile amylases. The other important observation was that the higher the amylase was, the increased incidence of pancreatitis you tended to present with. So there did appear to be a functional association with clinical features. Okay, so this was our second paper, and we'd moved on in terms of at the time of the operation, we were measuring the pressure in the choledochus, in the bile duct itself. And this is a series of 25 children. And this is a key observation that we made, that your choledochal pressure, as it went up, if you like, was associated with a smaller amount of bile amylase. And this is the key graph that we produce. So the higher the pressure, the lower the amylase. So it's an inverse relationship, Okay, and this was the sort of defining thing which closed the loop for us. So we continued to measure bile amylase, we continued to measure pressure. And in this study, we then sent off the excised choledochal malformation for an analysis, if you like, of the epithelium, the lining epithelium of the choledochal malformation. So this was the setup at the time, and indeed we still do it. So at the start of the operation, through the sort of window of the abdominal wall, the first thing we do before any dissection is just put a pressure needle in the choledochus itself, measure the pressure when it comes to a steady state, take then a sample of bile off for biochemical analysis amongst bile amylase. We also measure other things as well, but bile amylase principally. And then we use the resected choledochus itself and sent that off to the pathologist. Okay, so what did we find out? This is a graph which confirms the inverse relationship between pressure and bile amylase. No surprises there, but bigger numbers. And with those bigger numbers, we were then able to subdivide into the various types that we had in our system. So fusiform, cystic, and the type 4. And what you can see here is a stepwise increase in pressure according to the type. So the fusiforms have the lowest pressures. The type 4, the combination, has the highest pressures. Okay. Now, in order to try and make this scientifically valid, you've got to have some kind of semi-quantitative scoring system for the epithelial lining. So we designed this, a scoring system from 1, which was normal, to 4, which was very abnormal. And in this particular example, you can see how abnormal it is. That orange is actually crystalline bilirubin. This particular example, there is no epithelial lining whatsoever. Clearly, a major abnormality of the epithelial lining here. So they varied from 1 to 4. So using that score, this is their pressures. And what you can see is, again, a stepwise increase in pressures from 1, which is virtually normal epithelium, to 4, which is virtually very abnormal epithelium. They've got the highest pressures. Now, this is not a surprise, obviously, if you've been taking what I've been presenting over the past few minutes or so. This is the relationship showing the bile amylase and that epithelial lining score. So what it shows is a stepwise decrease. So the ones with the most normal epithelium have the highest bile amylases. The ones with the most abnormal epithelium, the ones with 4, have the lowest amylases. Now, again, it's not a big jump to say goodbye to Dr. Babbitt. This is evidence. This is actual physical evidence, and it completely refutes his particular mechanism. I'm not refuting the actual observation that pancreatic juice gets into bile, but as a mechanism for a choledochal malformation, this is completely against it. Okay. Now, I haven't got a fancy reproduction of the paper title in this one. This is our 4th study. The reason for that is it's just been accepted by the Journal of Pediatric Surgery. And what in this paper we looked at and concentrated on were the type 4s, type 4 malformations. So what did we do? Well, this is a typical type 4. And you can see the dilatation in the left hepatic duct here, and you can measure that dilatation on ultrasound. So this is the series that we just presented. Just as an aside, these come to surgery at an older age group, which again suggests an evolution of the natural history. Some of them were actually cirrhotic at the time of surgery. These are just the measurements. Please don't take any notice of the actual measurements themselves, just that we can actually do it. And when you've got measurements, when you've got numbers, then you can try and determine relationships. An interesting observation was it was only the left duct size which correlated with the size of the common bile duct, not the right. But this is the key graph for this. And as I say, this is new data, not presented before. On the y-axis, we've got the common bile duct diameter. So it's uncorrected from age. And on the x-axis, we've got the age of the patient. Now, this is the relationship between diameter and age. And actually, when you first look at it, there is no, you can't put a line through these spots themselves. So what we did was divide them according to the level of their median bile amylase, which happened to be 2000. So we had 2 groups. We had a low amylase group, which were the blue triangles, and the high amylase group, which were the red circles. And then it seems to fall into two different groups. We've got one group down here, which are the younger. They're all less than 5 years of age. And we've got one group here, which are the older ones, but lower common bile duct diameters, smaller, if you like, malformations. And the low amylase group proved to be dominantly cystic, and the high amylase group proved to be dominantly fusiform. So to us, there seemed to be a distinction that we could make even in these type 4 lesions. So what can we conclude from this particular part of my presentation on etiology? Well, we can conclude that I think there is a genuine distinction. So we've got ones that are characterized by high pressures, low bile amylases, and by implication a narrow pancreaticobiliary duct junction, and those are predominantly cystic. The other group are low pressures, high bile amylases, and a wide junction, free reflux, and these are predominantly fusiform. It's the pressure which causes the histological damage in our particular experience. Our latest paper, concentrated on intrahepatic dilatation, also seems to suggest that that distinction between cystic and fusiform holds for the type 4s as well. So the type 4C, cystic or low amylase, younger and dominantly bigger as well. Whereas the fusiforms, high amylases, are usually older, certainly by the time they come to surgery, and again, smaller diameters. Okay, so that's how we got to our current iteration of the classification. And as I say, it's built on observation and also pathophysiological evidence as well. But you want to talk about surgery, I'm sure. So I'm going to talk a little bit about our surgery, which is open surgery. And this is my series from 95, which is when I was appointed as a consultant at King's. And we've now done over 200, which in European terms is a big, big series. And there's our classification, just to remind. And this is the breakdown that we've got in this series. So a roughly equal distribution between cystic and fusiform, and 17% that were type 4. Okay, so let me just run through a few details. Now, this is relatively standard. You can find it in most textbooks, particularly if I've written the textbook. So this is through a limited right upper quadrant incision. I always do an on-table cholangiogram, even if you've got excellent preoperative imaging, as the key to dissection is knowing the anatomy. We start with mobilization of the gallbladder down to the actual dilated common duct itself. And the first bit to be divided is usually the common hepatic duct. That's usually the easiest thing to divide. And having done that, we can then mobilize it from the bed, where the portal vein is, down to the level of the pancreas. And typically, we need to mobilize inside the pancreas itself. And that brings you in very closely to the main pancreatic duct and the common channel as well. And there's only one thing worse than damaging the common channel, and that's not knowing you've damaged the common channel. You will certainly find out in the first few days after the operation. But even if you suspect that you have injured it, you do your damnedest to try and identify that leak and close it off, because it clearly could be a problem. I'm a keen advocate of choledochal, whether they're purposefully designed cholangioscopes or small bronchoscopes or even ureteroscopes. And what we're looking for is obviously strictures, stenoses, stones within the intrahepatic ducts. You've got one opportunity to get inside the intrahepatic ducts. Make sure you use that opportunity correctly. Clear any debris out. Otherwise, you're just literally storing problems up for the future. The reconstruction is a standard roux loop, 40 centimeters or so retrocolic, and typically would use 5, 6, or even 7/0 for the babies as the suture of choice. Now, it's a commonly said that bile ducts never read anatomy textbooks, and that's certainly true. You've got to be very well aware of variations in biliary anatomy at the top end. The principle is that every duct, every segment drains into the roux loop, no matter how the actual ductoplasty is that you use. So you may need to be a little bit experimental in achieving that, whether you leave an island of proximal cyst or not. The main aim is to achieve duct drainage. So we had to do some kind of proximal ductoplasty in 7% of the series. Alternatively, down at the bottom end, you need to be absolutely secure that the common channel is both free of debris and also patent at its distal ends, no ampullary cirrhosis. And that's particularly so if the child is presented with pancreatitis. So we often use a choledochal scoop, certainly for those dilated distal common channels. And we've had to do even a transduodenal sphincteroplasty in 7 of the series. So complications, very important to be absolutely assiduous in outlining your own complications. Otherwise, you have no idea where you are. I would advocate always nowadays the Clavian-Dindo grading scheme, which is the current standard for listing complications. And in this grading scheme, we have 2. Grade 1, these are minor, not requiring intervention, single wound infection. Portal vein thrombosis, worth spending a moment just to detail that one. This actually was in a child that who presented with a perforated choledochal cyst, again, a known complication. And we've seen this before in spontaneous biliary perforations as well, that presumably it's the bile in direct contact with the portal vein, and it causes a fairly slow onset thrombosis as well. This particular case was only picked up on the 3-month ultrasound that we performed. We followed it. We did even an endoscopy. There was no varices, so it hasn't had any consequence, but it is a possibility. I've had 2 bile leaks, both minor, not requiring intervention, and simply allowed to be treated along conservative lines. Single pancreatic duct leak, which again settled, and an exacerbation of pancreatitis. These are the ones requiring intervention. Gastric outlet obstruction, actually this was where the mesentery was stretched out over the first part, like a bowstring, if you will. That required another operation, 3 adhesive small bowel obstructions, 1 incisional hernia. And this was an unusual complication. This is a retained common bile duct. You remember I advocated going as far as you dare towards the common channel, but clearly I hadn't had any spinach on this particular occasion. And I left this bit here. And she came back and we did an ELCP and showed that it was full of debris, cleared it out endoscopically, and actually she's now an adult. She hasn't had any other problems. So it's just a complication to be aware of. So let's address some controversies now. Let's really deal with the controversies which are important in our time. Now, there's one obvious controversy I do not want to get into, and that is, who is the best batsman in the world? Could it be Virat Kohli, or is it really Rohit Sharma, both top of the Indian Premier League standings at the moment? I am not qualified to answer that, but I may be qualified to perhaps contribute on the role of laparoscopic surgery and also the choice of biliary reconstruction surgery. So let's start with laparoscopic surgery. I am actually a keen advocate of laparoscopic surgery, but not for choledochal malformations, certainly not for biliary atresia, but not for choledochal malformations. Hopefully I'll try and convince you why. Laparoscopic surgery for choledochal started in northern Italy in 1995. This was a paper produced by a team no one had ever heard of, and subsequently hasn't really heard of since. If you read the report, it's actually very coarse. They use 4O catgut to do their anastomosis in a child. But nonetheless, definite milestone. But the biggest star in laparoscopic choledochal excisions and reconstruction has to be this man, the man on the left-hand side. This is Nguyen Thanh Lien. And he produced this amazing paper with experience of over 400 patients. Now you can tell he's a superstar because of the company he keeps. The guy on the right-hand side is Shinzo Abe, the Japanese Prime Minister. That's what happens when you're an important laparoscopic surgeon. Anyway, let's have a look at in detail at this series that he published. 400 cases. That's not a misprint. 5 years. The throughput in Hanoi must be amazing. He had 2 variants of reconstruction, hepaticoduodenostomy and hepaticojejunostomy. Let's look at the reported complications. He had 8 leaks, 2%. Now look at this, the length of stay. So this is a guy that does 400 of them in a Hanoi center, and his length of stay is 6 days. Now, my length of stay in my series is 6 days. It's a myth in this particular operation to suggest that they go home earlier. They do not. They do not. And this is not one of the reasons you really should be pushing if you want to do laparoscopic surgery for this particular operation. In terms of the other post-operative complications, 1.5% incidence of cholangitis in the duodenostomy group, halved in that of the jejunostomy group. So a higher incidence of cholangitis with duodenostomy. And what was certainly higher was his rate of bile gastritis, 3.8%. And that is a complication peculiar to the hepaticoduodenostomy. Now, I've written a couple of chapters actually with Liam for my books, and he's obviously contributed how to do it laparoscopically. And this is his video. And you'll clearly see the traditional, or hear, traditional Vietnamese music being used. And this is a video from a master. This is, remember, he's been doing 400 of these at least. And you can see that in the hands of a master, it looks like it's an excellent operation that could be performed in under 5 minutes. The one thing you also know about laparoscopic videos is they're heavily edited. So before the music hits its crescendo, let's just carry on and address the situation from those who have not got the magician's hands of Liam. So this is a European study. This is a European study of choledochal malformations from the entire Netherlands between 1989 and 2014, 91 cases. It's an uncommon condition in Western Europe. The thing I've chosen to spotlight is the surgery. 79 were open, but 12 laparoscopic. And these were obviously by laparoscopic experts who developed the entire science of laparoscopy. But look at the complication rate. 22%, 1 in 5 of this entire cohort had a complication, completely different, not only to my experience, but also to Liam's experience as well. 22% leaks, cholangitis, etc., etc. They looked at the reasons for that, and there were 2 risk factors. One was laparoscopic surgery. If you don't do it a lot, you get problems. The other at-risk group was the infants at who are less than 1. And that's obviously because of the delicate nature that you might need to do for the reconstruction itself. Let's just choose a series a little bit closer to home, not necessarily my home, but yours. This is a series from Tamil Nadu on laparoscopic management of choledochal cysts. 110, but this was a combined series of adults and children, 55 children. The mean age, now it's unusual for European, North American series, it's older, at 7 years of age. And that just, I'm sure, tells you a little bit about the natural history in the Indian environment. 2 forms of reconstruction, surgical time of it's over 3 hours or so. Again, length of stay, 6 days. It is not diminished by doing this operation laparoscopically. But what I wanted to focus on was the complications. 2 bile leaks from 55, so 4%-ish. Similar rate for cholangitis. 1 stricture, 1 bile gastritis. I'm a little bit skeptical about that because I think that just implies they're not really looking for it. I think you have to have a lower threshold, do an endoscopy, and you will see bile gastritis. So can you improve laparoscopic technique? Well, there's one obvious way. This is what I would call the Chandigarh way. Buy yourself a robot. This is the Da Vinci robot, which is really the only one on the market. The problem with that is we can't afford it in most centers in the world. The upfront cost, the cost to buy it is about $2 million. Just think how many Lamborghinis and Aston Martins you can buy with $2 million. And they don't really tell you the extortionate running costs as well. So it's an expensive proposition for most people. Indeed, in the UK, there's only 2 pediatric surgical units that have access to a robot, one in Leeds and one in West London, which you all know is a very rich part of town. Both of them were not bought by the NHS, they were bought by private means. Now, it's expensive, and that clearly doesn't harm the intuitive share price, which is going up and up. And it's one person said that the Da Vinci robot was a solution in search of a problem, and that's certainly well worth repeating. But nonetheless, I certainly would agree that in the older child, not necessarily the babies, but the older child, this might be one way of improving the technique of anastomotic, the anastomosis. So what are we left with in laparoscopic reconstruction in choledochal? Well, probably only cosmetic, But if you look at the number of ports that this operation does need, and particularly if you're going to do a jejunal-jejunostomy outside of the abdomen, which most people would do now, if they're going to do a hepatico-jejunostomy, these are fairly big incisions if you add them all up. And this is our typical operation nowadays. This is what I would call a constrained incision. So the choice of bile duct reconstruction. As I've said, there's two real choices, I think. The standard is undoubtedly a roux loop, but people level saying it's unphysiological. It delivers the bowel into the jejunostomy, which is not where God intended. So the alternative might be the hepatico-duodenostomy, but there are others. People have designed conduit operations using bits of the bowel, again, to deliver it into the first or second part of the duodenum. And these definitely are physiological. The question is, are they better? So let's just sort of look at a little bit of evidence in defense of the roux loop. This is César Roux. He was a surgeon, a Swiss surgeon, working at the end of the 19th century or early 20th century. This is him at work. Not much evidence of PPE in the Switzerland where he worked. No head covering, no gowns. And this is our contribution. This is a paper published in 2015. And what we were looking at was the growth. It's a key issue in children. They have to grow. So we were looking at the influence of the roux loop on growth. This is just the series we utilized. But the key graphs of this one, this is on their weights. So we obviously measured their weight preoperatively, but when we saw them postoperatively in our clinics, we measured their weights and heights and continue to do so. So this is their weight. And the obvious observation for this is it's measured in standard deviation scores. So 0 is normal, 0 is normal. And the obvious observation from this is that they are underweight. And that just implies that the choledochus itself is clearly having a pathological effect. So they start off underweight, and after the operation, they get better. So they've had roux loops, an unphysiological operation, but they seem to cope with it. And they cope 3 years and more. This is fairly early as far as a long-term follow-up study, but nonetheless, the principle is the same. And it was the same with their heights. They're shorter than average. They're shorter than they should be. And that corrects. They exhibit catch-up growth when you reconstruct their bile ducts, when you reallow the bile to flow from their livers. Okay. So, hepatico-duodenoscopy. One more thing to add, and it's a story. Tadhana, you remember him, of course, of the classification. He was actually an advocate of this in open surgery. He was an advocate of hepatico-duodenostomies in open surgery. And this is his first report in 1981, 19 cases. But look at the complications. 5 out of the 19 had cholangitis postoperatively. You really shouldn't see this after a choledochal reconstruction. Second publication, 67 cases. 10 of them had already required reoperation for stones and stricture. It's not a great operation. This is his group. They started then comparing it with roux loops, and they highlighted bile gastritis as being peculiar to those in the hepatico-duodenostomy group. But this is the killer, almost literally. This is a case report, 2002, and it's of a child, a girl, 13 months of age, who had a cyst, choledochal cyst, excised and reconstructed using an HD, and she represented 18 years later, with bile duct cancer at the level of the anastomosis. As a result of that, Tadhana's team abandoned the operation and only performed roux loops from then on. I do hope that this experience is not repeated for those that are doing this operation laparoscopically, and you do it because it's a shortcut. For those of you who believe in systematic reviews, this is just to highlight the propensity of bile reflux gastritis in children with hepatico-duodenostomies. So that brings us on to almost my final slide, shortcuts. The roux loop laparoscopically is a difficult operation. So one of the solutions is obviously to bring out the small bowel and do the first anastomosis outside, or alternatively just do one anastomosis, the hepatico-duodenostomy. The anastomosis, whether it's hepatico-duodenostomy or jejunostomy, is difficult. It takes a master to really do it successfully without leakage. Solution may be robotic assistance, if of course you can afford it. But as this man, Bryant McGill, said, every shortcut has a price usually greater than the reward. So can I conclude from my second part on surgery? Open surgery is the gold standard. You'd need several bars to buy a robot, by the way. Hepatico-jejunostomy seems to be the way that we would consider carrying on with, being safe, reliable, and having few complications with a proven long-term record. If there are any comments, obviously we're going to address this in the next few moments. But if you want to write directly to me, I'm very happy to receive any emails. And obviously, if you want to sell your robots, you can buy a few copies of this particular book. Thank you very much.
Thank you, Mark. Thank you so much. That was an excellent presentation.
There we go.
Round, can you hear me?
I can hear you perfectly.
Okay. A huge round of applause for you on your presentation. That was an excellent presentation. And we have had an audience of almost 170 people on YouTube who are watching live for this presentation. And there are quite a few questions about your presentation. So if you allow me, I can just read them out to you and then you can answer. So the first question is from Dr. Sudeep. How do you differentiate between type 1 choledochal with IHBRD with type 4?
Oh, well, by definition, they're the same.
Yeah, yeah.
That's the point. That is the point. So if you've got intrahepatic bile duct dilatation, I accept that in those that present with obstruction, part of the dilatation may well be due to the whole thing, but nonetheless, it is very difficult to be able to distinguish those two. So mostly we talk about them as type 4. If you want to be pedantic, you could probably just look at the ultrasound after the operation. Now, in our type 4s, now I didn't show you this as evidence, but in our type 4s, the intrahepatic duct dilatation gets better in virtually all. And this is, I admit, an experience in children, might be different in adults. So you could say they're all the same. If you've got dilatation, that's just a type 4.
Okay. Dr. Prakash is asking, is there an entity of form frustae in your class? And
okay.
If so, what is the cause as per the amylase reflux theory and the pressure theory which you have highlighted?
Okay, so in terms of form fruste, this was a phrase by John Lilly. John Lilly was an American surgeon working in the 1980s. But if you look at his original paper, what he meant by form fruste was that it was a disease in evolution. So what he observed was children with common channels who didn't have much biliary dilatation. And he reasoned that if you left them for a few more years, they would then get the biliary dilatation. Now, actually, when you look at his original series, I think he reported 5 children. They had an awful lot of biliary abnormalities. So there was some with intrahepatic cysts and stones even. Nowadays, when we're a bit more precise in measuring the common bile duct diameters with ultrasound, the majority of the ones that perhaps have been labeled as form fruste could really be described as fusiform malformations. They've got the common channel, they've got the dilatation, and they usually present with symptoms, typically pancreatitis. Now, I have seen some cases where they've just got a common channel and absolutely no dilatation. And again, they seem to come to your attention because they get pancreatitis. So I accept that, but I would tend to use the word common channel syndrome rather than imply form frust. But it's a word that's out there, definitely.
Yeah, I think the syndrome is the more accurate term to describe that. We agree with that. And so the next question is how to differentiate CVD dilatation due to a stone or a choledochal cyst with a secondary stone inside it.
Yep. I sort of mentioned this right at the very start. Sometimes it can be you experience. Why should a 2-year-old child have a stone, for instance, unless there's an underlying choledochal malformation to cause it in the first place? In a lot of teenagers, obviously, they do genuinely get stones. It's an increasing observation that we make in most Western societies. And they just get stones that obstruct the common bile duct and they just dilate. And that's not a problem. That you take the stone out, the dilatation itself comes down to normal. They genuinely haven't got an underlying choledochal malformation. So sometimes it's just the experience of yourself or the radiologist when looking at them. The pattern is different. Those that have got a very obvious cystic morphology are very easy to differentiate. The ones that may cause problem are the relatively smaller fusiform malformations. So it may be a distinction. Obviously, if you make the observation they've got a common channel as well, that pushes it into the choledochal malformation group rather than it's the stone that's just caused the dilatation. So you can use other observations to perhaps push it one way or the other.
Okay, thank you. There is a question about the antenatally diagnosed choledochal malformations.
Yeah.
Do you watch them if they are without any symptoms? And if you operate them, what is the optimal timing of surgery for them?
Okay, so one thing you should always think about when you're presented with what someone calls an antenatally detected choledochal cyst, and they're all cysts, by the way, we've not had a fusiform present in that way, is could it be a cystic biliary atresia? Now, the key distinction is obviously, is this baby jaundiced? So if the baby is jaundiced and has got a cyst, it could be either. It could be a cystic biliary atresia or an obstructed choledochal cyst. And in which case the decision for operation is easy. You've got to do a laparotomy. So you don't wait in those. The problem a little bit, and it may be just a conceptual problem, is those that aren't jaundiced. So they cannot be a biliary atresia. And in those where you see them, you measure the bilirubin, it's coming down to normal within 2 weeks or so, you can be confident that their problem is that of a choledochal cyst, cystic choledochal malformation. When should you do the operation? We tend to take the view that you should do it as early as you feel confident in doing the operation, to be honest. So we tend to consider it from about 4 weeks of age. I don't certainly leave it to 4 months of age, which some people have argued. Now, those of you perhaps that do this operation laparoscopically would be a bit more reluctant to do it on the younger, smaller babies and leave it till they're oldest to allow you to do it laparoscopically. I think that's wrong. That's a logical problem. I don't think you can really support that. If they need an operation, they need an operation, just because you can't necessarily do it the way you wish to do it. So anytime from about 4 weeks, we've not had any issues with subtle changes in liver fibrosis, which is what some people would perhaps suggest. So their livers always seem to be okay if they've lost their jaundice.
Okay. Dr. Archana is asking, any difference in liver cirrhosis between low pressure high amylase and high pressure low amylase type of choledochal malformation?
So the only cirrhotic cases we've had, and I appreciate that's because we tend to diagnose them, I think, earlier in the UK than you perhaps are able to do in India. So I think your cirrhotic rate is probably higher. They all are high pressures. So it's the pressure in our experience, and as I say, we've not got that many of them. They've all been high pressures, and the kind of pressures are 20 millimeters of mercury, 25 millimeters of mercury, and they've had problems. However, having said that, during the operation, ensuring drainage, even if they've got histological cirrhosis, The ones we've had, the handfuls of the ones we've had, have not had any problems in the long term. We've had 2 that I think are now 15 years post-operation. We follow them all up. We do ultrasounds, etc. Do serial biochemistry. None of them have had any problems after that operation, even the ones that were histologically cirrhotic at the time of operation. So you overcome their pressure, they get better.
Okay. Yes. So there's a few questions about the roux loop surgery. Do you get any mechanical problems in the follow-up of these patients? Sometimes they get adhesive obstruction, roux loop obstruction.
So we as I said, we had 3 with adhesive small bowel obstruction. So that's what is it, 1.5%. You'd anticipate a 5% in any laparotomy. You might say, well, we do hepatoduodenostomies. They've had no risk of adhesive small bowel obstruction. That's not entirely true. If you look at series of hepatoduodenostomies, even they have a risk of small bowel obstruction. So it's very definitely a risk of complication. As regards the roux loop, as I say, if you do a proper roux loop, you've got one opportunity to do it correctly. You really shouldn't have a problem of stenosis in the long term. We try and follow all ours up to the age of 16, 17 years of age. We always do serial ultrasonology in them, and that's the best way in terms of post-operative investigation of determining whether you're going to get future problems. So to reiterate, all the type 4 dilatations all came back to normal. We've never had any stones post-operatively, and that I attribute the use of the choledochal. So when you look at the older Japanese series from the 70s and 80s and the like, they really had a problem. 10% of them kept coming back with stones in the intrahepatic bile ducts, dilated intrahepatic bile ducts, and almost certainly this was because they hadn't recognized there was debris within it, or the anastomosis became stenotic. But thus far, I'm touching wood here, we haven't had those kind of problems. So choledocoscopy strongly advocate. Even those that do it laparoscopically, try and do some kind of visualization of the intrahepatic ducts. Okay.
There's a question from the same viewer. Is there any difference between anti-colic versus retrocolic Roux-en-Y hepatoduodenoscopy?
Is there any difference? Well, there's no reason not to do it retrocolic, to be honest. You are creating a fairly closed mesentery. So we do close all the spaces around the retrocolic window to stop stray loops of small bowel getting in the way and internal hernias. We've never had them. With an anti-colic anastomosis, this was originally really advocated for those that are having roux loops for cancer, for pancreatic cancer and the like, where you're trying to keep away from the cancer. But there's no real advantage, and you are creating potentially a fairly big hole beneath the mesentery of the mobilized roux loop. So again, I can see theoretical advantages of not disadvantages inherent in an anti-colic loop.
Okay. You spoke a lot about the bile gastritis in the hepaticoduodenostomy patients. Can you throw some light on how this diagnosis of bile gastritis was made in these?
So the original ones, if you look back at the series, it was symptoms. So these are children and I guess adults as well who kept complaining of intermittent abdominal pain, vomiting, dyspepsia, and they were endoscoped, and you can see the bile. So the original people, like Tadhana's group, had a very low threshold for endoscopy, which confirmed their suspicions. And there's not a great deal you can do about it. As I say, it's difficult to diagnose without endoscopy. So if you attribute it just to bellyache and the like, and don't do your endoscope, you will underestimate the incidence of bile gastritis. The reason is obviously that you're pouring bile into typically the first part of the duodenum, because you're mobilizing all the duodenum is inevitably, you have to mobilize it like a cocker maneuver to bring it up to the common hepatic duct. And the nearest bit to the common hepatic duct is the first part. So the bile is getting in and presumably it's refluxing through the pylorus. So it's well recognized as a problem. Some people have suggested, well, if I mobilize it even more, could I do the anastomosis to the second part? So some people have suggested, okay, but it will be the medium and long term really that would demonstrate any true benefit of that. If you can, hypothetically, you might reduce the incidence of bile gastritis. The problem long term for bile gastritis is it may be potentially a kind of predisposition to malignancy. Certainly, the people that adults with stomach cancer, that is one of the predisposing factors. But we don't know. We don't know in children.
I always felt that the laparoscopic surgeons always do the hepaticoduodenoscopy close to the pylorus without mobilizing the duodenum. That in any way will give a very high incidence of bile reflux into the stomach. So that factor has to be corrected, and there has to be some technical improvement in that. Okay. So Dr. Ramesh is asking that what is the pros and cons between short and long roux loops?
Roux loops, okay. Actually, in choledocals, no difference at all. So I can say hand on heart, touch wood, I haven't really seen any cholangitis postoperatively. Now, you might say that's because we do a 40 centimeter, which is relatively long choledocus. But in truth, it probably doesn't matter for choledochal malformations because the bile flow is just so good. That's not the same for biliary atresia. Their bile flow is never that good. And they are predisposed to cholangitis, whether you make it long or short. Well, I think there is an advantage for long roux loops for that, but there's many people that say that even in them, there's no real advantage. But I think their reason for cholangitis is different. They don't have the bile flow, the actual torrent of bile coming down that perhaps keeps the bugs away from the proximal roux limb. So it probably doesn't make a difference in choledocals.
And what is your preference regarding the roux anastomosis with the confluence, whether it is an end-to-end anastomosis or it is an end-to-side?
Does it make a difference? So I started simply doing the traditional, if you like, end to side, like a T junction. But for the past 10 years or so, I've used a stapler to do the anastomosis. And using the stapler creates invariably a very acute angle. And we've noticed no real difference, as I say, but nonetheless, it's a little bit quicker to do it. But that does create almost a side-to-side anastomosis.
Okay. And what is your experience with perforated choledocals who present in emergency? And
so we've had probably about 3, maybe 4 from memory, who presented with a perforation. Typically, they're cysts, they're large cysts, and the bile leaks into the right paracutic colic gutter typically. So they often present with appendicitis or what appears to be appendicitis. And I think 2 out of them had an appendix-like operation before it really, the diagnostic penny dropped. So the surgeon opened up as to do an appendicectomy and they recognized bile in the peritoneal cavity, closed up and referred on. So it can be a problem of diagnosis. You can find that's a more delayed diagnosis. As I said, this peculiar complication of portal vein thrombosis seems to be a particular problem if you've got bile washing your portal vein. So we described it, we've published on this, with spontaneous perforation of the bile duct, particularly when the perforation is posterior. So there is this entity in babies whereby, for whatever reason, hole appears in the bile duct, and normally it's anterior, so it washes into the general peritoneal cavity, but sometimes it can be posterior. And they seem to be peculiarly predisposed to portal vein thrombosis again at some other point post-operatively. So it's not an immediate thing. For those, we've heparinized them.
Another scenario related to that, for patients presenting with severe cholangitis, would you recommend a preoperative percutaneous drainage of the cyst, or you would just wait and manage conservatively initially?
So in all that series, I'm going to say we've not had to do that. There might be 1 or 2 in the early in the 1990s. So it's not been a common type of presentation in our UK practice. Similarly, I mean, one could say one could use ELCP and stenting for those kind of procedures, and I would not be adverse to simply doing a small exploratory laparotomy and putting a T-tube in. as a temporizing measure. We've done that, for instance, for perforation, for instance, but also equally well, cholangitis that you're really not getting on top of. Drainage of the bile through a T-tube would be a reasonable thing to do as well.
One last question. What is the incidence of cholangiocarcinoma which you have seen in patients with Roux-en-Y hepatocholangiostomy? 0?
Yeah, I'll put my hands down. It's none. Now, this is a children's series. But again, if you look at the older Japanese series, they did have a distinct incidence of malignancy. But if you teased apart their statistics, malignancy happened in those with chronic problems. And typically there were stones, dilated intrahepatic ducts, had them for years, recurrent cholangitis, and then they became malignant. So the silent malignancy is very uncommon. And again, in our particular case, now obviously we've only been following these up for a relatively short space of time, particularly when you equate it with the human experience. But my predecessor, Ted Howard, was doing this kind of operation since the 1970s. And I'm not aware of any of his operations, if you like, coming back with any kind of malignancy. They would be adults. They would be outside of our sphere.
Okay. I think, Mark, that is it. There are still questions coming in, but maybe we'll pass it on to your email later on for you to answer.
Fabulous.
And an excellent presentation, and we had an excellent viewership over the YouTube channel. And I'm sure there would be a many more people who would be watching this as a recorded version on the same place. And there is a huge round of applause for you, and everybody is complimenting you for giving us these excellent perspectives about the amylase and the pressure inside the choledochal cyst, and then the perspectives of Roux-en-Y versus hepatocellulostomy. So I'm sure you'll be coming up with more details and data in future, and we will hear more about them from you very soon. So I would really thank you on behalf of IAPS for accepting this webinar presentation, and it was really great hearing you.
Thank you very much. I just reinstate that it is a privilege. It's always a privilege to both come in person, obviously, but also to deliver this. It's one of those things that you really like to get your work across to other people as well. And this is a forum which I think the IAPS excels at. Thank you very much.
Thank you, Mark. Thank you so much. So we'll end the stream now, and